Damian McNamara with Global Medical News Network. I'm here at the Society of General Internal Medicine annual meeting. I'm here with Dr. David Edelman of the Durham VA Medical Center in Durham, North Carolina, and Duke University. You presented a study about group medical clinics, and you compared them with a control group looking specifically at blood pressure and glycemia changes. Can you tell me a little bit more about that?
The way the group intervention worked was that the patients would be put into groups of 7 or 8, and they would come to a group clinic every 2 months for a year, in addition to all of their usual primary care. There was an education piece in which the nurse would provide some education in which the topic was driven by the patients. The design was for it to be an interactive session. The nurse tended to use very few slides for half hour to 45 minutes, and instead to try to engender discussion among the patients. While this discussion was going on, the pharmacist and the physician were in a back room, quickly going through the patient's medical records, through the patient's blood pressure and blood sugar logs, and coming up with a strategy for managing blood pressure and blood sugar. At the end of the teaching session, the patients would each get about a 5 to 10 minute breakout session with either the pharmacist or the physician, in which the plan would be negotiated with each patient, and there would be a final plan made. And this could include medication changes, diet changes, exercise changes, or simply advice to start taking all the medications the primary care provider had been offering. So in the intervention group, the group visits arm of the study, patients had a mean drop of about 14 millimeters of mercury of blood pressure, and the control group dropped a little over 6 millimeters of mercury, and that was a statistically significant change. We saw that change, most of it by 6 months, and it improved a little bit more from 6 to 12 months.
Now, in terms of the A1C results, they weren't quite as dramatic. Could you tell me about that?
No, they weren't. We improved hemoglobin A1C in the intervention arm by 0.9 percentage points, which you'd think would be really good, but the VA usual care patients also improved by 0.6 percentage points, and that difference was not statistically significant, and at 0.3% is really pretty small clinically. These patients had had diabetes for an average of a little over 9 years, which means their primary care provider had been hammering at them for 9 years to try to get the hemoglobin A1C under control, and it hadn't worked. The majority were on insulin already. We had fewer options, fewer therapeutic options for these patients. We had real difficulty trying to make as much of an impact on these patients as we did in blood pressure. And that's what I really think is the key issue and the key difference between those two outcomes.
I was asking you if you think the intervention is still worthwhile.
Yes, definitely. What do patients with diabetes die of? What do they become disabled from? To a certain extent, it can be kidney disease, it can be amputations, it can be blindness, but it's good old garden variety coronary artery disease, heart attacks, congestive heart failure that really causes the most mortality and morbidity in this population. There is a wide literature that essentially proves that the control of blood pressure and cholesterol is much more important in preventing those outcomes than is the control of blood sugar.
What about the future? Are there any unanswered questions you still want to look at?
Oh, yeah. This ain't cheap, and we have cost accounted all of the data to the microsecond. Every time our pharmacist called a patient, she hit a button on a timer on a computer and started the clock running. So our project for the next few months is determining how much this costs to do and whether it makes sense for a large system like the VA or a large HMO or even a payer like Medicare to organize these things from a cost-benefit perspective. We think it's unlikely to be cost-saving, but it could have manageable cost and large benefit over a short number of years. Okay. And we'll know that hopefully by next year this time.
This has been Damian McNamara with Global Medical News Network.